So today I would like to talk a little bit about freeze-all or freeze-only of the embryos in an IVF treatment cycle. I am Dr. Amit Shah. I'm one of the reproductive medicine consultants practicing in London in NHS as well as a private setup. So we know that increasing numbers of fertility specialists these days have started to stagger the embryo transfers by performing elective freezing of all good embryos. The logic behind doing that is to provide the embryos a more physiological environment for implantation. The initial data is very encouraging, where it seems to show that the implantation rates and hence the live birth rates seem to be much better in a frozen embryo replacement cycles when compared to fresh cycles. The group of patients where this seems to make the most difference is young PCO patients who are more likely to over-respond, as well as the group of patients where we would like to perform pre-implantation genetic screening and carry out embryo biopsies on day 5, followed by which the embryos need to be frozen before the results are available and transfers can be carried out later, at a later date. Now, the question is that can we apply this logic and this strategy for the rest of our patients? In other words, can we actually move to a concept of freezing all good embryos for every IVF cycle that we carry out, and do you think that we can improve the outcome? Now, next question I have is about the actual terminology that we have all been using, a terminology of freeze-all embryos. Now, this is, in my view, quite a misnomer. That when you tell your patients or when you put out leaflets telling patients that our strategy is to freeze all embryos, they assume that all the embryos created from the eggs that they produce will be frozen. Now, we have to therefore be a bit more specific from medical legal point of view, as well as to making sure that our patients understand clearly what we mean. And hence, I would suggest, like many other people have done so far, that we change the terminology from freeze-all to freeze only good embryos as a strategy to make it absolutely crystal clear. Now, the main question is that does it improve your live birth rate when you freeze the embryos? Would it apply to older patients? Would it apply to patients with poor ovarian reserve? Would it apply to patients with endometriosis? What are the group that will benefit and what are the group that won't benefit? Well, what we clearly know from the most recent publication from Fertility and Sterility by Wong et al., which has put through a very nice thought in their paper, where they have shown that when you see raised progesterone levels prior to embryo transfers in a fresh cycles, you will see reduction in implantation rates, irrespective of the quality of the embryos. They've also shown that in increasing age group of women with increasing age group, i.e. older women, would also have a benefit if we defer their transfers, though the statistical analysis and the sample group that they had collected for older age group patient is still not convincing. So we do know now that progesterone rise will reduce the implantation rate. Now, what we don't know is what is the cutoff of progesterone that we should use. And different clinics use different cutoffs. Different countries have different measuring measures of progesterone in nanogram, picomole, etc. So it gets all very confusing. What also that we don't know is that at what level of progesterone should we use as a cutoff. So that is something which is yet to be discovered. We still need good randomized controlled trials to figure that out. What we also are proposing now, that just like raised progesterone level, we think that the raised or significantly raised estradiol levels have also got an impact onto the implantation rates and outcome of the cycle. Partly, we do know that this is probably true from our over-responding PCOS group of people, but we still don't have any robust studies and data available to prove this. But this could also become one of the mechanisms by which the embryo implantation may reduce. The other bit that I want to highlight is to see that how do we actually then select our group of patients if we were to apply a selective strategy for freeze only of suitable embryos. I would propose that the group of patients that we should strongly consider freezing the embryos and deferring the transfer is a group which is the young PCOS group, which are more likely to respond. Also the group of patients who are going to go through pre-implantation genetic screening, and perhaps the group with raised progesterone level during the stimulation phase. Though the only problem with that group of patients is that we don't yet know the exact cutoffs, and different people will use different cutoffs for progesterone levels. In short, we all know that one size does not fit all. We are all different human beings. We all have got different way of responding to medications and drugs, and therefore, as a clinician, it is very crucial that we make made-to-measure, bespoke plans for each patient that we see. Even if you have got a very busy fertility unit, it is not that difficult. Dr. Goody and I at Homerton tend to do this very well, where we review all our patients' notes, we make plans for these group of patients, and we make and we believe that we make a significant difference to the outcome of our patients and our treatment cycles. The one more aspect of a deferred embryo transfer that I want to bring up, that potentially this could increase the cost of the treatment cycle, which is what some people have argued, because you're doing a fresh cycle, freezing the embryos, and then doing a frozen embryo replacement cycle. My argument against that is that if you can achieve a live birth in the quickest possible way, then eventually the patient will not have to go through a second and a third cycle of treatment with IVF, and hence we may actually end up costing less for these treatments rather than costing more. People have also discussed about the emotional burden that patients carry, because when you defer the treatment cycles for 6 weeks and 8 weeks, they often get very, very unhappy, very upset, they're very stressed out, and I think therefore it's incredibly important that when we are going to put this strategy in place, we keep our patients very well informed, we counsel them appropriately, and we provide them the right kind of support so that they clearly understand that what is the logic of doing this. A issue has also been raised about frozen embryo replacement cycles, as all of you must know, that frozen embryo replacement cycles also increase the chances of large for gestational age babies. Very unlike to a fresh embryo transfer, where small for gestational age babies are more common. So that could bring in potentially another issues in the antenatal time frame and intrapartum care, that these group of patients may end up needing more interventions or more invasive operative deliveries, etc. But that is something that we need to be still looking at more carefully and figuring it out. I hope that the 2 randomized controlled trials that are awaited, including one large trial happening in the United Kingdom about whether elective freezing of embryo transfer would improve the outcome of a treatment cycle for all or not, will probably throw some more light onto this issue. But I want you to actually think about this very carefully, very seriously, and I would certainly recommend that if you select your patients appropriately, then you will get better results with elective freezing of suitable embryos followed by a deferred transfer. Thank you very much.